Hello, welcome to the latest COVID-19 Carroll County virtual public forum. My name is Kyle Ulveling. I'm a cardiologist with the Iowa Heart Center in Carroll, and I serve as Chief Medical Officer for St. Anthony Regional Hospital. With us tonight is Dr. John Evans, a family medicine physician from the McFarland Clinic in Carroll, Nikki Schwering, a registered nurse and the Director of Carroll County Public Health, Sarah Schulte, a registered nurse with Carroll County Public Health, who's also been very instrumental with the vaccine rollout the last several months. And then we have a special guest, Destiny Simons, an Arcadia resident who contracted COVID-19 and has agreed to share her experience with us and with the public. I'd like to thank everybody for viewing tonight. You might notice if you're watching this on different versions of media that you might only be seeing one segment at a time. There's links to the St. Anthony webpage that'll be able to show you the entirety of this video. So to start off with, I'd like to just go through some statistics on where we are the first week of May 2021 compared to where we've been previously. So our current positivity rate is 5.3% as of today. Now, if we go back 4 or 5 months, we were frequently encountering positivity rates in the 25%, 20%. There were state benchmarks at 15% that if we could get below that, certain good things could happen as far as restrictions on travel, things like that. It's wonderful that we've gotten down to 5%. We have seen a little bit of an uptick over the end of March and beginning of April, probably coinciding with travel and get-togethers, things like that. But overall, it's markedly improved, undoubtedly because of a successful vaccine rollout thus far. The vaccination rate, we can use kind of two different numbers. As of right now, 41% of Carroll County's total residents have been vaccinated. That means they completed either their Johnson & Johnson vaccine or they completed both of their Pfizer and Moderna vaccines. If we look at just Carroll County residents who are eligible, which means 16 years old and above, at least 65+% have received one injection. We're doing very well. For the better part of April, Carroll County was in the top 5 states or counties in the state of Iowa out of the 99 for vaccination rate. We'd like to see this continue. We'd like to see Carroll County to still be at the forefront, leading the state and helping all of us out as neighbors, getting back to normal activities. There are 3 current vaccines still approved. The Pfizer, which is 2 injections 3 weeks apart. Those are, it's eligible currently for 16-year-olds and above, but we'll talk later through this process that may change next week. The efficacy of the Pfizer vaccine has been published at being 95%, meaning a 5% chance of getting a symptomatic case of COVID-19. Now, we'll also talk about how that efficacy may be different on different variants of COVID-19 later in this talk. The Moderna is 2 injections 4 weeks apart, and that's currently eligible for 18-year-olds and above. The efficacy was very similar, 94.1% compared to the 95% for the Pfizer. So the Johnson & Johnson's different. It's a different technology than the Pfizer and Moderna vaccines. The efficacy is, the published efficacy is a little less. It was in the 80%. But it's in a single injection, which offers a great deal of benefit for logistics, for people having to get into a vaccination clinic once versus twice, and also for transport. All 3 vaccines look like they have a slightly less efficacy against the UK variant of COVID-19 than the original wild type from 2019 that we dealt with in 2020, but still more than adequate. It is still the best way of controlling not just the wild type, but the UK variant and possibly future variants. It is free for individuals. Now, many clinics may ask for your insurance information. That's because for the supplies, for the staffing, insurance may be charged for that, but in the state of Iowa, there is to be no individual contribution. So your insurance should not put any of that vaccination charge onto you, and that has been the case for the last several months. So with that kind of background, I'd like to reintroduce Destiny. Again, she's an Arcadia resident who's agreed to share her story of contracting COVID-19 with us and with the public. So I turn the mic over to you.
Thank you, Dr. Ulveling, and thank you for having me. December 31st of 2020, I tested positive for COVID-19. My first initial symptoms were not being able to taste or smell. I first realized it when I couldn't smell, and I was a little concerned at that point. I went in and got tested, and I tested positive. I was very achy. I had a slight cough. I never did run a fever the entire time I had COVID. And I just felt lethargic. I would have chills, and my days went on like that for about a week. And then the following Wednesday, I woke up and I was severely short of breath. My pulse ox, which I kept checking at home, was in the lower 80s, and I was not feeling the best. So I called my doctor, and he had me come into the hospital. Went to the ER. They ran a bunch of tests on me. They did a chest film, EKG, things like that. They did end up admitting me. My O2 sat was, like I said, in the lower 80s, and my D-dimer was elevated, so I was at risk for blood clots. So they put me on blood thinners, and they put me on remdesivir, which was the IV medication for COVID-19. I was in the hospital for 5 days, and I had a collapsed left lung, pneumonia in my right lung. I was not doing well. I was very scared and very concerned, but I had very good care. I was here at St. Anthony, and I was taken very good care of while I was here. I then was discharged on day number 5, went home, and I was doing fine, still very short of breath, still very achy, cough. Every time I coughed, my chest hurt really bad. I just felt like I had something stabbing me in the middle of my chest. No one else in my family got it. My daughter was vaccinated, and she stayed in a different room, obviously. My husband was in a different room than me. And I continued along with that progress. I stayed on inhaled steroids, oral steroids, blood thinner, various vitamins, vitamin D, vitamin C, zinc, and they kept me very, at ease, that I felt like I was getting better. Then I developed COVID hands and feet, where I had blisters on the bottoms of my feet and on both my hands, very painful. They were kind of like water blisters. And I had that for a good 2 weeks. And then I developed shingles the following week on the top of my head. So I dealt with that. I have had an echo of my heart, and everything came back fine with that. They did have me do pulmonary function testing, and I have developed asthma related to the COVID. They obviously don't know if the asthma is going to go away in time, or if I'm going to continue to have it. So I still use the inhaled steroids and a rescue inhaler. I still am on baby aspirin. I am off of the injectable blood thinners that I was put on when I was in the hospital, because my risk for blood clots was elevated. And I had sweats, chills, cough, body aches, hair loss, fatigue. I ached everywhere. I had memory loss. I almost started my kitchen on fire because I forgot that I put grilled cheese on the stove. It took me a long time to get my full function back, where I felt like I could walk up and down my stairs, where I could walk around my house. And now I'm going to pulmonary rehab here at St. Anthony. I'm on my 3rd week. And it's helping me a lot. I feel like the shortness of breath is still there when I am exerting or doing any type of exercise, but it's still there, but it is improving over time. I was off of work for a total of 12 weeks, and I felt like even at that point, it was hard for me to go back to work. I was very tired, couldn't hardly get through a whole day. So I went back 4 hours a day. for 2 weeks. And then after that, I went back to my regular 8 hours. So I feel like I'm definitely improving, but it's been a very scary process.
So last week of December was the infection date or diagnosis date. We're
Correct.
now 4 complete months past that.
Right.
What percentage would you say you are back to the way you felt at the beginning of December? In other words, weeks before you caught this.
Probably 60 to 70%. Yeah. So I'm getting there. It's just a long process. And so the shortness of breath and the chest pain is still there.
So I've always been a little uncomfortable with the term long hauler, because I don't know if, how would you describe the prolonged symptoms, things like that? What phrase or how would you describe it?
I still feel like the shortness of breath and the chest pain was the same at the beginning, just not as severe. And I feel like new things pop up. It's not just the same symptoms I had at the beginning. It's new things that come up. I've gotten the blisters back on my hands 2 times. I have had new sores on my head since I've had it and been back to work. I've had still the sweating at night. Like I feel like my temperature is changing. Like I could be running a fever. I never have, but I have felt like that. And it's a long process. So COVID long hauler is a good description, just because it's COVID that's lasting a long time. And I feel like eventually, hopefully, it will go away completely, but no one knows that. And so it is scary, and I hope that other people don't have to experience it. I do know a gentleman from my hometown that lives in Ankeny that was in the hospital for 144 days with COVID. And so there are much worse situations. I never had to be on a ventilator. I didn't have to have oxygen, but my symptoms were very severe.
Well, thank you, Destiny. I really appreciate it. I think, the 4 of us have done quite a few of these talks, but I think it really helps also to hear from somebody who's experienced it like you have.
Well, thank you for having me. And I hope that if people have questions, they can always reach out to me and ask me questions. And I know all of you are willing to do the same for them. So I appreciate you having me.
Thank you very much.
Thank you. Have a good night.
So Dr. Evans, one of the first questions that have come up has been, if others have been vaccinated, why do I need to? If I don't want to, but the rest of the group has, shouldn't that be good enough?
So good question. I think the answer is short and long. The short answer is so that we can get the virus to go away sooner. The long answer is that we need a large percentage of the population. I'm not sure what that number is. A lot of people say more than 80% to have long-term immunity to COVID-19 and its variants to get it to go away. The analogy I like to use is a forest fire. So a forest fire will continue to burn as long as it has fuel. Once it runs out of fuel or it can't burn the trees anymore, it will burn up and go away. But if there still are pockets of infection, if there are still people getting it, it will continue to burn, it will continue to smolder, it will continue to spread. The longer it spreads, the more likely it is to develop variants that are resistant, and possibly the vaccines won't be as effective. And then it would lead to more long-term need for vaccines, boosters, yearly shots, etc. So if we can get the fuel away from the fire by getting people vaccinated, then the fire will burn out and it will go away. We have seen this with other viruses similar to COVID-19. The SARS virus and the MERS virus did a similar thing, and hopefully we can accomplish that. The problem, the big challenge here is this is so worldwide, and so we live in a society that is very mobile, and all the travel keeps things spreading. So individually, if you're going to get it, you're going to get it locally. And so you're going to get it from your family, your friends, your neighbors, your coworkers. And but globally and regionally, we need to get as many people vaccinated as can so that we can get this to burn up and go away and not come back.
Absolutely. Another question we got was why, when we talk about herd immunity, why aren't we using natural immunity? Why don't we just say that, well, if you got it, you're good. And so if I've had COVID, I shouldn't need to get a vaccine. Well, there's a problem with herd immunity that what we know with the most accuracy is if you had a symptomatic case of COVID-19, you probably have sufficient native antibody-mediated immunity for about 3 months. And past 3 months, it is absolutely not uniform. People who got less sick than others still had better antibodies later on. We know this locally, and when I say locally, I mean Carroll, West Central Iowa, state of Iowa. We've had a lot of people over the previous year, after they got COVID, go to attempt to donate plasma. Well, when convalescent plasma was one of the main treatments we had, a lot of people who had COVID tried to donate and were told after just 3 months, they didn't have high enough titers to donate. So the problem with using just natural immunity, or I got infected, so I'm good enough, is that there is very little uniformity or rhyme or reason on how long you'll actually be immune for. And that's very different with the vaccines. While we're gonna learn about 12-month immunity later on, we know 3 and 6 month is very uniform, and it's a lot more predictable as far as the efficacy. Anybody else have anything to add on that?
I would just say that the immunity that the vaccine affords is the T-cell long-term immunity. And there's a big difference between that and the short-term IgG immunity that you get from the natural infection. So in this case, the getting the vaccine is better for long-term, no question. And it's because of how it affects the immune system. So to get true herd immunity, we have to have people vaccinated.
Absolutely. And Sarah and Nikki, we've seen this locally where somebody, a non-vaccinated person who had a previous case of COVID-19, recovered, tested negative, and then caught it again. I mean, we've seen this locally.
Absolutely. We have seen it a handful of times or more that they've said, oh, I had it back in December. I went to Mexico, had a test to come back. It was negative. And a month later, they're positive again, and they're symptomatic.
So one of the reasons for getting us out of this via vaccine is it is a much more effective and straightforward way of, as Dr. Evans mentioned, getting rid of the fuel for the forest fire. So, Nikki, originally, when vaccines started coming out, there was a statement about not needing to get the vaccine if you've been recently infected with COVID-19. Now, that's not the case anymore, right?
Right. So originally when the vaccine started coming out in December of 2020, obviously the demand far outweighed the supply. So when the supply was less, the Iowa Department of Public Health kind of wanted us to prioritize who we were giving that vaccine to benefit the most, who would benefit the most from it. So originally, as we were trying to get the elderly population, the nursing home, healthcare workers, the people that had recently had COVID, we know that they may have that short-term immunity. So we just asked them to wait until the supply got more, until we were able to have adequate vaccine. So, now that the vaccine is in better supply and the demand is lower, they're saying that as long as you have recovered and you're symptom free, so as long as you've recovered your 10 days, you're out of isolation and your symptoms have resolved, we encourage you to get the vaccine as soon as you're able to.
So Dr. Evans or Sarah, have you seen anybody where we're consistently telling people to wait 90 days at this point? Yeah, that's what I've seen as well. Go ahead, Dr. Evans.
No, only unless they received treatment. They received antibodies or treatment, then they need to wait. But anybody else, I've heard 30 days for symptoms to clear, but 90 days is not necessary at all.
And Dr. Evans brings up a great point. Your personal physician or provider, if you know that you received monoclonal antibodies, if you received some of the special treatments, that might put you in a special category, but it's not a uniform recommendation that everybody who had COVID wait 90 days. So if there's any personal question, absolutely ask your primary care provider because they will know how you were treated. But for the vast majority of people who contracted COVID-19, you do not need to wait the 90 days. Thank you, Dr. Evans. So one question that we've been getting is about adverse effects, and I think that's a total fair question related to any treatment. We think about doing more formal consents when we do a surgery or a procedure, but every time we offer a treatment, we may talk about pros and cons, but we don't necessarily put them in the formal language of risks and benefits and possibility of adverse effects. So for one, to put it simple, as our patient testimonial showed earlier, the symptoms of COVID-19 have a far greater potential of causing adverse effects, of keeping somebody out of work, of causing morbidity and death than the COVID-19 vaccines do. So it is fairly common to have a mildly sore arm, assuming that the arm was the injection point, and possibly some mild fatigue for 24 hours. That should be expected, and that's the systemic response of your immune system revving up. That's not a bad thing. That's not you getting infected or anything like that. That's your immune system starting to rev up. About 5% of people, so 1 out of 20, will experience more significant symptoms of fever, headaches, and severe fatigue. So severe fatigue that might keep somebody from going to work for a day, but that's 5%. 95% of people have mild to no symptoms. Contrary to what might be intuitive, it's actually, as we get more senior in age, we are less common to experience significant adverse effects. And it's partly due to how robust our immune system responds to vaccines. But while a mild amount and a usual amount, if somebody gets a sore arm from an influenza vaccine, they should expect a mildly sore arm for the coronavirus vaccine. The three other panelists, have you seen anything different from that?
No, certainly the younger people seem to have more of a reaction, which fits with the more robust immune system. And I think that has caused some people to bypass getting the vaccine because they're worried about the side effects. But I think as Destiny, our patient here demonstrated earlier, young, otherwise healthy people can get very, very sick with COVID-19. A lot don't, but you don't know. And a sore arm and aches and chills, headache are annoying, but the chance of becoming vaccinated and keeping it from spreading and not taking your chances with the side effects of the wild virus, I think, are far outweigh the risks of not getting vaccinated.
And I honestly, I might be the least touchy-feely emotional person on this panel, but one of the reasons why I was on the first day that vaccines were offered in Carroll County was that this decreased the chance of me giving it to my family, you know, to my teenage boys who are not eligible for the vaccine yet, that I'm more than willing to go through mild side effects to protect my family. And from a more selfish point to make sure I'm remaining at work, that I'm not having to get sick and miss out of days and weeks of work. The pros far outweighed the potential risk of a worsening sore arm in that for me. All right, Dr. Evans, one of the topics that came up multiple times was, can you explain what went on with the pause on the Johnson & Johnson vaccine? What the adverse effect that the concern was about it, and then just kind of give us a run through on why it's available and some background.
Sure. So the Johnson & Johnson vaccine was the third vaccine to make it to the market. It's a different vehicle than the previous vaccines, the Moderna and the Pfizer vaccine. It uses an adenovirus platform. And I think a couple positive things about this is it lets us know that the surveillance system that's in place is working, because they noticed an uptick in some unusual reactions, and they decided it needed closer scrutiny. So they paused the delivery of the Johnson & Johnson vaccine. It had already been over 6 million doses given, but they noticed a small uptick in a rare condition called sinus thrombosis, which is a blood clotting disorder accompanied by low platelets that seem to be exclusively in young women between 18 and 50. And there were 6 cases originally identified, and I think a few more on the fence. But the same condition, unfortunately, can occur with COVID itself. COVID is a prothrombotic situation where you can get more blood clots, and this is possible with COVID as well. In fact, you're more likely to get it through the COVID virus than you are through the Johnson & Johnson vaccine. That being said, I think they did due diligence to be sure that this wasn't a deeper problem or other problems. And I think it's important that if you're considering the Johnson & Johnson vaccine or any of the vaccines, you discuss it with a provider to see what your risks are. Certainly young women and women who have a family history of blood clots or are on estrogen therapy for any reason should pause to think. It's still a very low risk, but that's a good discussion to have with your provider. It's back being distributed again, and it seems to be going well. The risks are again low, close to less than 1 in a million for the general population. It's very popular with the college campuses because it's a one and done vaccine. So a lot of the college campuses are getting the Johnson & Johnson vaccine. They're also doing workplaces with it, which is very convenient for shift workers and people that maybe can't come back at the same time to get the second dose. So I think it's been reviewed and evaluated. I think it also goes back to people's concerns that these vaccines were rushed and that they weren't vetted like other vaccines were, but that is not the case. All of these vaccines have been vetted and been scrutinized for adverse side effects. They had to pass all of the same criteria to be released. They just were able to do it in a faster fashion because the government subsidized the manufacturer's ability to do this, and they didn't have to wait in between to get approval. They were able to go on to the next step. So these vaccines have been incredibly well studied, and nothing is safe. Certainly not getting the vaccine and getting the virus is not safe. And but I think it's a good. One of my children just got the Johnson & Johnson vaccine here last week. So I think it's reasonable, but if you are female between 18 and 50, you have blood clotting or are on estrogen, I think it's a good discussion to have with your physician or provider.
And correct me if I'm wrong, but one of the big reasons for the pause was also to educate us as healthcare providers, because not all blood thinners are the same. And as you mentioned at the beginning, this is not just a blood clotting disorder, but a low platelet disorder. And it was to educate us to make sure if we diagnose it, that we use the right treatment.
Correct. So heparin is usually used for blood clotting disorders, but in this case, heparin actually makes it worse. And so some of the, there was one death, I believe, from this and some significant cases, but now that they're not using heparin, in these cases, the results are far more favorable. So yes, it was a good opportunity to learn more about it.
So the most recent published literature as of this past week was, now that it's being recognized better, it's such a rare disorder that many of us may go a career without seeing it. But and now that we know how to treat it correctly or more correctly, the vast majority of people are having a complete recovery, and not just a partial, but a complete recovery from the initial insult.
Correct.
It's been mentioned before that, you know, this is an emergency use authorization. This didn't go through the formal process of approval, therefore it's experimental. Therefore, we're using the public as guinea pigs. That is definitely not the way I would phrase it, but how would you answer that?
Well, like Dr. Evans just mentioned, you know, they've been through formal testing. They've had to go through all of the testing like any other vaccine has. And, you know, COVID-19 is not the first coronavirus pandemic that we faced in our lifetime. Again, like Dr. Evans said, the SARS and the MERS outbreaks of 2003 and 2012, the coronavirus vaccines were started back then. So these vaccines have been studied for well over 20 years. The companies like Moderna, Pfizer, and Johnson & Johnson didn't have to start from scratch. They had science and technology then that they were able to build off and test out these vaccines for us. And, you know, we've talked about the efficacy of the vaccines. In Carroll County, we know of less than 10 people that have been vaccinated and been through their 2 weeks or, you know, through their vaccine series and been reinfected with COVID again. So based on over the 8,000 people that we vaccinated in Carroll County, you know, we could see that number as high as 400. So less than 10 is great. So we know that the vaccines are doing their job and doing what they're supposed to be doing.
And I believe we've actually seen this reproduced outside of our locale also, that in real world scenarios, we're seeing better than a 95% efficacy rate as far as people reporting positive symptomatic COVID after a full completion of a vaccination protocol. And that might be because in a trial situation, you know, the Pfizer and the Modernas were closely following up all their trial patients to make sure that they didn't get COVID again, where we could have some asymptomatic COVID, but still, we have less than 10 after 8,000 vaccines. We are far above a 95% efficacy just in Carroll County.
Right, which is so great. It's our way to get back to normal and take back our summer and get back to what we should be doing.
One of the future successes is going to have to be with young adults. We've done a very good job of getting our senior citizens vaccinated, of getting our essential workers vaccinated. But where we see now a lot of the increasing positive cases coming from young adults. So what would you say as far as what does the future hold for vaccinating youth and young adults?
You know, and just for a little background on this, I kind of researched our COVID cases for the last 14 days. I just went back 14 days and I tried to find all the people that were age 40 and younger that are testing positive for COVID. So in the last 14 days, we had 51 new cases of COVID. And of those 51 cases, we had 32 of them that were 40 and younger that were actually positive. So that's 63% of the people who just tested positive are of the younger population. And that's what we need to focus on. And with Pfizer possibly next week, hopefully moving their vaccine down to age 12 and older, that's really going to help us get a hold and a grip on the COVID cases we're seeing in the younger ages. You know, I think just looking at the data that I collected or we collect over the last 14 days, the more people that get vaccinated, especially in the younger ages, the quicker we're going to get back to our summer activities, the quicker school and normal activities can resume. Even bus routes, if we look at the bus routes they were cut short a lot, and parents are really having to take their kids into school and pick them up, which is an inconvenience for them. But if we could get our numbers back down, and the more people we have vaccinated, the more we're going to be able to get back to normal.
So on the breaking news this week of Pfizer, hopefully next week lowering their age of eligibility down to 12, we won't be the only county wanting Pfizer. That'll be a popular ask of every county, but we would certainly try to prioritize the supply of Pfizer we would get for that school-age children, 12 to 18, that aren't eligible for the other two vaccines. Would that be fair to say?
Absolutely, yes. And I'd even be willing to, if we can get it done fast enough and get the Pfizer vaccine, to go into the schools to help get the age 12 and 18 students vaccinated, to help speed up the process and make it more convenient for the parents so they don't have to take off work.
There's a lot of 12 to 18-year-olds that can't get themselves independently to a clinic.
Correct.
One of the largest resistors we've seen to people getting vaccinated has to do with pregnancy and/or fertility. It became an early resistor, and it's remained so. As an obstetrics provider, what can you tell us? What do we know, and what are the best recommendations?
So, no one can predict the future completely, but a lot of studies have gone on with this, and a lot of pregnant women and women of childbearing age have been through this with the rest of us, and they have contracted COVID, they have been vaccinated, and a lot has been learned. Just to dispel the myth that the vaccine causes infertility, there's no scientific evidence to support that. That was, I think, kind of a social media worm that got running, and it unfortunately had traction, but there has been no evidence that it decreases fertility. So the notion of doing trials in pregnant women and in nursing mothers and in young children has never been something that this country has been comfortable with. So we have to rely on expert opinion and on kind of anecdotal data. Quite a few women were pregnant or became pregnant and had the vaccine. There has not been any reported increased adverse side effects in pregnant women, nursing mothers. And there has been noted that in the moms that are pregnant that have been vaccinated, the antibody titers in their newborn children then are positive. And so they have passed on passive immunity to their newborns. How long that will last, don't know, but the major societies, obstetrics and gynecology, maternal fetal medicine, pediatrics, family medicine, all encourage pregnant mothers and nursing mothers, it's okay to get the vaccine. I think, again, you should discuss it with your provider. The first trimester is always kind of tricky because it's the highest time for miscarriages and neurological development. And so I think some people favor doing it not in the first trimester, but I think it's a discussion that you should have with your physician. But I would certainly agree with the experts on this one as usual. I think the data is sound, and the mechanism of the virus is such that because it's not a virus, it's not the virus itself, it's not a killed virus, it's not a modified virus, it's merely a protein that is being carried over and replicated, that it's very safe and effective. And so again, if you are considering to become pregnant, you are pregnant, nursing, et cetera, discuss that with your physician.
And on a similar point, but just to belabor it, this vaccine does not change a recipient's DNA. It does not change a recipient's ability to produce mRNA. It codes for a protein to allow a recipient's immune system to create a large amount of immune response should it be exposed to that protein again.
Correct. It does not influence our DNA or our replication. It doesn't get to the nucleus. It merely provides a literally a messenger to bring it into the body so that the body can respond to the protein and develop antibodies to protect ourselves.
What's made some news in the last probably month has been Pfizer especially has went on record saying that they will very likely be releasing a booster for people who have already completed a vaccination series later in 2021. So, Dr. Evans, why would we need a booster later this year?
So I think some of that remains to be seen. There's certainly the concern that some of the variants that are developing, the UK variant and the variant in India and things, are less susceptible to the vaccine than the original wild type virus was. So I think one of the theories there is if you have even higher doses of antibodies in your system, you will be able to ward off even some of these variant viruses. It's hard to know whether this is going to be a one and done pandemic or whether this is going to be something that we see year after year, like influenza, that consistently mutates and changes course and has to be chased every year. It certainly looks more, from the beginning of this, it seems to follow more of the other viruses like it, the MERS and the previous SARS-1 virus, which did not have rapid mutation and yearly endemic problems, but time will tell on that. But it again goes back to the need to get as many people vaccinated as possible now, so we can extinguish these variants and burn out these fires so they don't have a chance to take hold and keep increasing and then end up mutating and causing problems year after year.
It's not surprising that we have a Brazilian variant, an Indian variant, and UK variant given over the end of 2020 and beginning of 2021. These three countries had dramatic outbreaks, nationwide outbreaks. I believe the statistics from India is that only 1% of the population is vaccinated. So it allows for this huge pass back and forth, more people being infected. And in general, the more times you allow this to keep reinfecting people, the more potential you have for a dominant strain to emerge. Is that fair?
That's what I understand, yeah. And it's, again, the faster we can keep this from spreading and get it behind us, the less chance it will to be able to develop new variants that are resistant to the original vaccine. And that's really the goal.
We've talked about getting a possible booster shot later in the year. How about we just talk about for people who have gotten the Moderna or vaccine first shot, Moderna or Pfizer first vaccine shot, how important it is to complete that second shot regimen?
Right. So while getting the first shot of the Pfizer or Moderna, it's a great first step. But we need to continue on and get that second one, whether it's 3 weeks later for the Pfizer or 4 weeks later for the Moderna. These vaccines were predominantly made specifically for the 2019 COVID strain that we were seeing. But as Dr. Evans was just discussing, there are new strains coming out. So that's why we do get some type of immunity with the first vaccine with the Pfizer and Moderna. But it's that second one that gives us that extra boost. That's why we call it the boost dose. It's the second one that gives us that boost that puts us up to that 95th percentile of getting our antibodies built up, of getting that immunity. So that's why getting both shots is very important. And I'd like to say also for Carroll County, all of us have done an outstanding job of getting our second dose for each vaccine. We at Carroll County Public Health, we keep a list of people who were there, they were out of town and they needed to reschedule. We have a list of those people, and it's about 10 or 15. I'm sure McFarland Clinic might have a few on their list to kind of catch up. But as we keep going, the supply is there. We're going to be able to get you that next vaccine that you need. And we're more than willing to work with you on when you can get it.
We don't want to encourage loosey-goosey behavior with getting that second one, because these aren't individual doses. They come in vials of 10 or more. So we, just to make sure we're not wasting doses, we want to try to keep people bunched together as far as on a day. But Sarah, if an emergency, if life happens and somebody misses their day number 2 day, we do have a little flexibility where if we have to make arrangements for a couple days late or things like that, we do have a little flex capacity, right? Where if they're a little late for it, they can still get in for their second dose, right?
Correct. We'll get you in as quick as you can, or as we can, whatever works in your schedule. And just to let you know, if you're past that 3-week or 4-week window, you do not have to restart the series. We'll just give you your boost, and in 2 weeks, you'll have that immunity built up.
On a tougher note, what if we plateau out and we fall far short of a true herd immunity, where, whether it's 70%, whether it's maybe a little bit more than that, depending on the variant, but if it's pretty clear we haven't reached it, what does that look like?
Well, that gives the virus a chance to keep burning. So it means that there still will be pockets where people that don't have immunity can still get the infection and then spread the infection. And that the longer it goes on, the longer it has the ability to mutate and to develop resistance to the vaccines that are out there. So it is very different than the flu vaccine that way. I don't think it's a foregone conclusion that this is going to be like the flu vaccine. It's going to come back and mutate I think there's a decent chance from the experts that I've read that if we can squash this out now, this summer, get as many people vaccinated as possible, that we may not have to deal with this in the future. But if we don't achieve herd immunity and it continues to smolder, we will almost certainly be dealing with this in the future with boosters and, probably yearly shots, and then possibly worse than that could be increased mutations, which require new vaccines, and yearly situations where we're getting a new vaccine every year, and that akin to the influenza virus, which is really what we don't want at all. In this world of travel and frequent meeting and worldwide businesses and the internet and so forth, and people, jobs and things are not isolated. So it really is it starts local, but it becomes a global issue very quickly. And so we need to help the other countries get vaccinated as well, as they bring in their travelers to our country and our area. We're susceptible if they aren't vaccinated and if they are carrying the resistant strain. So this is definitely needs to be a local, regional, and national, worldwide approach to getting as many people vaccinated to get that herd immunity to squash this out the first time.